My name is Amanda Choflet, and I am the Director of Nursing for Johns Hopkins Medicine for Radiation Oncology. My clinic actually is a series of 5 clinics that spans the Baltimore and Washington, D.C. area. We implemented a screening, brief intervention, and referral to therapy program at our main academic clinic in East Baltimore, at our East Baltimore campus at the Johns Hopkins Hospital. And we have plans to expand the program to the other 4 sites in the very near future. So for the purposes of this little talk, I'll just speak briefly about where we're at with our implementation of SBIRT in our East Baltimore campus and some of the challenges that we have kind of worked through in the last 4 months. It's been 4 months. So the clinic that I work in is an extremely busy academic facility. We have about 10 attending physicians in our radiation oncology practice, about a dozen nurses and an additional 10 nursing-related staff, and 12 residents. We see approximately 400 patients per week in on-treatment follow-up and consult visits, and we treat anywhere from 100 to 130 patients per day in our radiation therapy linear accelerators. So we're a very busy clinic. We have a lot of churn. And the patients, when they come to us, have usually been diagnosed with cancer already, and we see them either as part of a multidisciplinary clinic, so we'll see them with medical oncology and surgical oncology providers, or we'll see them just in isolation for a radiation oncology appointment alone. And usually the patients, when they come into our clinic, will interact first with a nurse, then with a resident physician, and then with an attending physician every single time they come. So consult visit, on-treatment visit, and follow-up visit. We noticed about a year and a half ago that we were having some issues with patients who were dealing with pre-existing substance use problems. So patients who, before they were ever diagnosed with cancer, had long-standing histories of drug or alcohol dependency. We noticed we're having a much harder time getting through treatment. It seemed like, this is all anecdotal, than patients who didn't have self-reported drug or alcohol dependency. In the last 18 months, we've really broadened but also sharpened our focus. And now, as a team and as a clinic, what we like to talk about is risky substance use. So substance use behaviors that either make it look like a patient is dependent on alcohol or drugs, or risky substance use behaviors that would put a patient at a higher risk for either disease or drug or alcohol related complications while they get through cancer treatment. And so what we did as a working group was we put together some literature. We looked at substance use literature, we looked at primary care literature, emergency medicine literature, and obviously oncology literature, and found that SBIRT seemed to be a pretty obvious and reasonable solution to this issue of assessing patients when they first hit our door. We decided to follow the CDC SBIRT implementation guide as a way to structure our initial implementation project, and found that to be a very helpful guide for us. Although it wasn't quite as prescriptive as we wanted to be, we just decided to adopt these strategies that had been used in primary care into our clinic, and then tweak them slightly for the oncology population. So we adopted, as a screening tool, we are using the AUDIT-C, the 3-question alcohol screener, and then we are also using a single question drug screener, which is have you now or do you now or have you ever used marijuana or other drugs? That question seems to be very relatable for patients and seems to be sensitive enough to capture most of the drug and issues that people are reporting to us. For a while during our initial implementation project, we were also using the ASSIST, the tool that was developed by the World Health Organization as part of their kind of SBIRT screening recommendations. We initially liked that tool because it risk stratifies into low, moderate, and high-risk categories, which in our clinic we thought would be important. We have since discovered that the ASSIST seems to add a tremendous amount of time to the initial assessment and doesn't necessarily yield much more sensitivity when it comes to placing people in high-risk categories or not high-risk categories. And so we've just decided to treat every positive AUDIT-C plus the single drug question into a high-risk category and every negative screening into a low-risk category. What we did to initially implement this project and teach people how to use the tools is we worked with a team of psychology consultants within our facility who were already doing motivational interviewing training through another grant on our campus. And we worked with them with the support of people like Paul and Dana Seal, with people here at the School of Nursing campus like Dr. Savage and Dr. Fennell, and really crafted a training program for our staff that was based in SBIRT principles and motivational interviewing techniques and also geared towards an oncology population. We developed 4 hours worth of training that we split up into 2 blocks of time, and we offered that training course twice. So we were basically offered 4 training sessions over the course of a four-week training period during September of 2015, and ended up putting 29 staff members through training. Not all of them got all of the training, but all of them got at least 2 hours of motivational interviewing training to really prepare them to establish that therapeutic relationship and be prepared to offer a brief intervention for patients who were high risk. We did some pre and post training assessments using some assessment tools that were created for us by the psychology consultants, but they did not yield very much change. They didn't show very much change in the pre and post on the tools, pre and post assessment tools. And one of the reasons I think that is the case is that SBIRT takes practice, and I think applying motivational interviewing techniques takes practice with one another, and frankly practice with patients. And so I am not, now that we've been doing SBIRT for a while in our clinic, I am not surprised that we weren't able to see very many changes in our staff members' ability to offer a therapeutic response to a patient after just a 2 or 4 hour training session. We have plans to repeat in 1 hour increments some of that training on a monthly basis for our staff members to help them continue to grow their motivational interviewing skills. And I suspect that if we were to repeat some of those tools after these booster sessions, we would see some actual improvement. But that's, the next question. We were able to work with a member of our team who is a physician and also an IT or information technology specialist, and she built electronic forms that became embedded within the electronic medical record that we use in our radiation oncology department. And these forms allowed our staff members to pretty seamlessly input the information that they were gleaning from their conversations with patients right into the EMR. If we are screening patients earlier in their treatment and initiating the referrals to the appropriate resources that the patients need, like social work or therapy for their risky substance use, that perhaps they would be able to not miss as many treatments or not miss as much chemotherapy. So there is I hate the word compliance, but there is a compliance to treatment component that very well may be affected by a good assessment and management strategy for substance use. I think that one of the biggest obstacles that we had and are still continuing to work through really have to do with competing priorities. And we know that time in the clinic is the hottest commodity we're dealing with. And one of the things that people in our own clinic and even outside of the clinic have always been very concerned with is how can you add one more thing to the plate of these busy clinicians who are facing such pressure to get patients in and out of rooms, and so that the next person and the next person and the next person can be seen. And for that reason, we chose a pretty simple and straightforward, 4-question screening tool, and like I said, have largely abandoned the larger assessment form. We find that there is no difference in time in the room with the patient for the staff who are screening the patient versus the staff who are not screening the patients. It really is more a matter of making it a priority when you're in the patient's rooms.